I'd just like to start off by saying I know this is a symposium about MRI, but I'm not an MRI expert. I'm a computer scientist and I work in sort of AI for medical image analysis. But the work I'd like to talk about today is about MRI and cardiac MRI in particular. So the title of the talk is Fairness in Cardiac MR Analysis, Tackling Biases Whilst Maintaining Performance. And this is kind of a bit of a potted history of some work we've been doing in my group for over the last 4 or 5 years. So as we're talking about cardiac MR, I'd first like to briefly introduce what this data is used for clinically and how AI can help cardiologists analyze it. So cardiac MR in general is considered to be the gold standard for assessing most aspects of cardiac function because of its good image contrast and resolution. And MR images sequences are used for a variety of purposes, but one of the main ones is using the Cine sequence to assess functional parameters such as left ventricular ejection fraction. This requires segmentation or contouring of the cardiac structures typically in the end diastole and the end systole frames of the Cine short axis sequence. And this needs to be done at multiple slices in the short axis stack. And in total, if you do this manually, it takes about 20 to 30 minutes. But increasingly, AI is being used to automate this process, and AI models have been shown to perform this task to a high degree of accuracy in just a matter of seconds. And there's even commercial tools that you can use to do this now. So that might seem like the end of the story, but I'd like to take a bit of a step back and ask what people actually want from AI in this context. So I suppose the thing end users like clinicians most care about with AI is whether it actually works. If a model could be shown to be 100% accurate in all scenarios, then people would, of course, trust it. But we all know that's never going to happen for any realistic problem. All models fail or perform less well sometimes. But there's more that we need to consider. When we talk about the performance of a model, we're usually referring to its overall performance. But what if the model worked well for some people and not so well for others? So it might work well for men and not for women, or it might work well for white people and not so well for black people. That would obviously be a concern, and that would lead to a lack of trust in the model. So we refer to these differing levels of performance between patient groups as bias. And actually, bias represents a form of discrimination because one group would be receiving worse healthcare than another due to misdiagnoses or inappropriate treatments. And this type of discrimination is actually illegal under GDPR and the EU AI Act. So as well as the risk of harming trust, there's also legal aspects to consider here. And for this reason, it's common to refer to groups defined by attributes like race, sex, or age as protected groups because they are protected by law from such discrimination. So studies into AI model bias originated in computer vision a few years ago. And since then, it's become quite an active research area. But actually, this problem is not unique to computer vision. People have started to look into it in medicine too, although only really in the past 3 or 4 years. So just the plot you can see on the right-hand side here is just a PubMed search for papers that have fairness or bias and AI in their title or abstract. So you can see it's going up quite sharply in the last few years. But until a few years ago, work had focused almost entirely on classification and regression problems, which are the most common type of problem in computer vision. But in medical imaging, segmentation plays a key role, and AI is widely applied to segmentation problems. So cardiac MR is obviously one example, but there's some other examples shown on the slide here. But until a few years ago, to the best of my knowledge, no paper had investigated bias in AI segmentation, even in computer vision applications. So that's what motivated us to look into this problem. So let's go back to cardiac MR now. Back in 2021, we decided to look into whether these AI models for cardiac MR segmentation could exhibit any bias. So in our first experiment, we trained a state-of-the-art CNN model, the NMUNet, using a large amount of data from the UK Biobank, all with manual ground truth segmentations. The task was to segment the 3 main structures visible in the short axis cardiac MR stack. So that's the left ventricle blood pool, the left ventricle myocardium, and the right ventricle blood pool. You can see where they are in the picture here. And we segmented these at both the end diastole and end systole frames and used the train validation and test splits you can see here. And for performance evaluation, we tested overall performance, but we also tested performance individually for different races and sexes. So before I show you the results of this initial work, I'd like to briefly just talk about the demographic breakdown of the UK Biobank. So as you can see here, it was roughly representative of the UK population at the time, which means roughly sex balanced, but not race balanced at all. The majority of subjects are white, with a relatively small number from the other races. So here's the results of using this large but racially imbalanced data set to train a cardiac MR segmentation model. So these are all DICE coefficients, and we can see that there is no sex bias, but that's to be expected because the training data were roughly sex balanced. But if we look at the race, in the results for individual races, there's up to a 9% reduction in DICE score for minority races compared to the majority white group. You can see that the white subjects had an average DICE score of about 93%, but all the other races were down in the 80s. And this is really significant in cardiac MR segmentation. It could be the difference between a clinically usable segmentation and a failure case. But what does this actually mean in terms of the use of these segmentations? So one of the most important things that cardiac MR segmentations are used for is to calculate ejection fraction, which is a measure of the health of the heart, and that's then used to characterize heart failure. And this characterization can lead to different treatment strategies. And heart failure is typically characterized as one of three types: either heart failure with reduced ejection fraction, heart failure with mildly reduced ejection fraction, and heart failure with preserved ejection fraction. And treatment options can vary for these three categories. Now, in reality, a range of measurements are used to decide upon this treatment, but estimates of ejection fraction are an important part of that decision process. So the table you can see here shows misclassification rates for the three categories of heart failure in the three columns there, but broken down by race in the different rows. And this is assuming that the AI predicted segmentations were used on their own to classify patients into their heart failure category. So we can see that these misclassification rates vary significantly between the races. The lowest misclassification rate is for the majority white subjects, whilst the other races have much higher rates. So if these automated segmentations were used to compute ejection fraction and characterize heart failure, it would lead to higher misclassification rates for the minority races. And this could in turn lead to wrong or missed treatment and potentially patient harm. So the obvious next question is, what can we do about that bias? Now, there are actually a wide range of bias mitigation algorithms that have already been proposed for addressing biased AI model performance. So the first thing we did is we evaluated three of these common mitigation strategies. The first one is reweighing, where we just reweigh the training samples from the minority group are weighted more highly in the loss function. In group DRO, the loss function is modified to maximize the performance of the worst performing protected group. And in oversampling, the batch selection procedure is modified to ensure equal representation between protected groups in each training batch. So effectively, we oversample from the minority groups. And to start with, we looked at internal validation, just using a holdout test set from the UK Biobank. So as you can see, the results vary quite widely. Reweighing, the top right figure you can see here, didn't appear to reduce the bias at all. Group DRO, the bottom left, made some improvements, but there was still some residual bias. But the most successful method was oversampling. So the method completely removed the bias and boosted the performance on black subjects to the same level as that of white subjects, with no statistically significant difference in performance. So this looked good, but let's remember that this is all under internal validation. The training data came from the UK Biobank, and the test data was just a holdout test set from the UK Biobank. So why is that important? Well, it might matter because there's been some prior work, and this is a paper by Jessica Shroof from Google Research at the time, which has shown that common bias mitigation algorithms are not always robust to the domain shifts that we see in external validation sets in medical imaging. And in particular, this paper looked at the type of complex compound domain shifts that we see in medical imaging settings. So What I mean by compound domain shift is that there may be many differences between training and testing data. It could be different imaging equipment, different acquisition protocols, different patient cohorts, and all of these differences combine to what we call a compound domain shift. And it turns out that this causes problems often for bias mitigation methods. So we decided to look into this in our work. So we curated a data set of black and white subjects from our hospital and evaluated our models on this. So I'm showing here the internal validation results at the top, just to allow easy comparison. But here's the external validation results. And we can see that overall, there's a bit of a performance drop, which you would expect. But actually, overall, the performance is still reasonably good. So it seems as if the segmentation model is generalizing quite well. But with respect to bias, we can see that things look quite different to the internal validation scenario. In fact, the baseline model gets a bit less biased, but there's still bias there. But now the oversampling model performs similarly to the baseline. So the fairness gains that we saw under internal validation didn't transfer to the external validation scenario. And from the statistical significance results shown by the stars, under internal validation, oversampling removed the bias, but under external validation, there's now significant bias. So this is something that we tend to see in medical imaging applications. Bias mitigation algorithms are typically developed and evaluated in computer vision, where there's either no domain shift because of their large training sets, or the shift is due to a single factor. But as I said, in medical imaging, things are a bit more complex than this, and we're seeing a few examples now of failures of bias mitigation, like we can see here. So I think in order to truly address bias in complex situations like this, it doesn't really make sense to apply generic mitigation algorithms, where these algorithms have no knowledge of why the bias is there in the first place. I think to try and really address the bias, we need to understand more about it and why it occurs. So this was our next step. We tried to look into where this bias was coming from. And the first question we wanted to answer was whether the source of the distributional shift between races was in the images themselves or in the ground truth segmentations, or in both. If there was a shift between the ground truth segmentations of the heart, then this would suggest that there are anatomical differences in the hearts of different races. If not, then the shift must be somewhere else in the images. So we trained AI classifiers to predict race, black or white, from either just the images, just the segmentations, or a combination of both. And because we were using an off-the-shelf ResNet model, we filled up the 3 channels of the input layer with the combinations you can see here. And here's the results. These were averaged over 10 runs. And the first and most striking thing to notice is just the level of performance. Remember that CINI cardiac MR images are formed from a stack of 2D images, each of which is a video with multiple frames over the cardiac cycle. But in this experiment, we used just a single slice and a single time frame. But still, the AI model could identify the race of the subject with 96% accuracy, which was very surprising because I don't think any cardiologist would claim to be able to do this task so well. So this suggests a strong distributional shift between the races, which is likely the cause of the bias in the segmentation models. The second conclusion comes from comparing the performance of the image-only and the segmentation-only classifiers. And we can see that there's a significant drop in performance when we remove the images from the input of the classifiers. And this suggests that the distributional shift is mostly in the images and not so much in the anatomy of the heart. So now that we know there was a distributional shift between races, we wanted to see if this was actually being encoded into the segmentation models. In other words, was the shift actually leading to the bias in the models? So to answer this question, we took a biased segmentation model and we did 2 things. We first visualized the latent space of the model using a dimensionality reduction technique, PCA, and we tried to classify race from this latent space. We knew from the previous experiment that we could classify race from the images and the segmentations, but now we wanted to see if there was still a separation between the races in the internal representation of the model. And here's what we found. So this is just showing the first 2 components of the PCA, but as you can see visually, there's a clear separation between the 2 races in pink and green. And the logistic regression classifier could classify race from the latent space with a similar level of accuracy to that which we found in the image classification results. So it seems as if almost all of this distributional shift in the images is getting transferred into the model, which means that it's likely this distributional shift is leading to the bias in the segmentation model performance. And the next question we wanted to ask was whereabouts in the images the distributional shift was originating from. So to answer this question, we went back to the race classification models that were trained on the cardiac MR images, and we used GradCam to produce attribution maps for the classifiers to see where they were looking when they classified race. Now, obviously, each image has its own attribution map, and there was some variation between them, but here's a representative example. And based upon a visual inspection of all of the test cases, what we found was that in many of the images, the classifier was looking at features outside of the heart, like subcutaneous fat, when making race decisions. Very few of the GradCam attributions were mainly focused on the heart region. There was also a sizable number that seemed to focus on image artifacts, especially around the edge of the image. And we originally thought this might be related to a difference in when the patients of different races were scanned, because early in the biobank project, there were very few non-white subjects, and efforts were made to increase representation of minority races. But we did an extra experiment where we controlled for this, we controlled for scan year, and we still found this effect. So our best guess is that these artifacts are related to body composition, such as fat regions, for example. So the conclusion from this experiment is that body composition is the main source of distributional shift between races. In fact, this ties in with existing clinical knowledge that's shown, a number of studies have shown differences in body composition between races. So let's just quickly review what we found out. So first, we know that the distributional shift in cardiac MR images between black and white subjects is mostly in the images. Second, we know that this distributional difference is encoded in segmentation models. And third, we know that spatially it's outside the heart. So in order to remove the source of the bias, the obvious solution is to eliminate these areas of difference. And for us, we can achieve this just by simply cropping around the heart area. So we devised this pipeline, a cascaded cropping pipeline, in which we first perform a region of interest detection step to find the heart, and then we crop around this region and finally run a segmentation model that's been trained on cropped images. And the hope is that because it's been trained on cropped images, that it will be less biased because it won't have access to this race identifiable information. And because this solution was motivated by our investigations into the source of the bias, it's an approach I like to call understanding informed bias mitigation. So let's see the results of this approach. And again, I'm showing the baseline and generic oversampling performances to allow easy comparison. So this is on the external validation set now. And now here are the results for two different models. One is just the cascaded cropping method I just described, and one is for combining this with the generic oversampling approach. And what we can see is that the cascaded cropping reduces the bias. Adding in the generic oversampling approach seems to improve the fairness still further, although actually both had no statistical difference between the two races' results. But what's even more noteworthy is the level of performance. So let's focus on the cascaded cropping with oversampling, the one in the bottom right. Comparing this to the baseline, you can see that not only has the fairness improved, but also the performance. Now, there's a common assumption in fair AI work, which is that there will always be a fairness accuracy trade-off. In other words, the gains we see in terms of fairness will result in reduced performance for at least one of the protected groups. And this assumed trade-off is sometimes used as a justification for not implementing fair AI methods. But that's not what we're seeing here. Not only is the fairness improved, but also the performance is improved, and it's improved for both protected groups. So just before I finish, I'd like to emphasize that this approach was made possible by an in-depth investigation into where the bias was coming from. Without this, we wouldn't have been able to target it with this cascaded cropping approach. And in this work, the solution ended up being quite simple, and it might not always be this simple. But I think that this type of understanding-informed bias mitigation is a really promising way forward for addressing fairness issues in medical imaging and could have application in a number of other areas. So just let me finish by providing a few take-home messages. So first, we need to acknowledge the limits of performance of many current AI tools. AI bias exists, and we should be open and transparent about this. We should routinely check for these biases when developing AI tools for medical imaging, and it should also be routine to report performance across a range of demographic groups. But this type of monitoring and reporting is only possible if we have access to demographic information. So I'd also like to call for the inclusion of patient demographics in public data sets as a matter of routine. It's normally not too much extra work to acquire this data and include it in public releases. I think the reason it hasn't been done widely is because people didn't think it was important at the time. So I'd like to change this perception. It is important, and we should all be doing it. When it comes to mitigating or addressing the bias, our experience has shown that generic algorithms can have some value, but the improvements in fairness don't always transfer to external validation. And this is different to the common experience in computer vision. And I think the difference arises because of the kind of complex and compound domain shifts we see in medical imaging. And finally, I believe that the key to overcoming this problem might be trying to understand the source of the bias. We've shown in cardiac MR segmentation that this understanding can lead to a simple and elegant form of bias mitigation, which not only improves fairness, but also improves performance for all protected groups with no fairness accuracy trade-off. So to close, I'd just like to thank these people who actually did the work. So Tiana did the majority of the work that I talked about today. Esther did the initial experiments and also co-supervised Tiana. And finally, Reza, who's provided clinical insight throughout. And if this talk has made you interested in fairness in AI, I'll leave this slide up here to talk about to show you information about the FAMI initiative, which organizes a number of events aimed at promoting discussion of fairness of AI in medical imaging. So thank you for listening, and I'm happy to take any questions.